I hope the weather's nice where you all are. And yeah, welcome to our session this morning, which is going to be looking at how we increase referrals to the National Diabetes Prevention Programme. Delighted to be joined by Alex Clegg from Reed Wellbeing, and Alex is a Senior Health and Wellbeing Manager, and I'll be handing over to Alex shortly. My name's Amy Aitken, and I work with the Boost team, and we set up this series of Connect and Learn sessions, each with a different kind of topic and theme. And the purpose of those is really to think about how we can share and spread improvement work around the North East and North Cumbria, and connect colleagues around specific topics to kind of generate ideas and hopefully be inspired to take forward some improvements in your own work, team or services. Just a couple of protocols as well before we get started. So please stay on mute when you're not speaking. Feel free to use the chat for questions and contributions. There will be also opportunities to ask Alex some questions at the end of his presentation. Please do listen with respect and be present as well. And yeah, do share what you've learned today, kind of teach it forward, as we say. We'll be making this recording available afterwards for people to access and have a look at. So yeah, do spread the word, and that would be fantastic. And we will come on to some breakout sessions, I should say kind of slightly later in the session as well, to kind of think about what we've heard from Alex and how we might be able to take some of that things forward in our own work. So yeah, without further ado, I will hand over to Alex, and we will hear from you about the work that you've been doing.
No worries. Thank you very much. Yeah, good afternoon, everyone, or good morning. So I say it's still not quite ticked over yet. So like Ian mentioned, I'm the Senior Health and Wellbeing Manager for Reed Wellbeing, and we're the provider of the NHS Diabetes Prevention Programme for the North East and North Cumbria. So just a very kind of brief overview. So I'm just conscious of today's kind of presentation, mainly looking at how do we increase referrals through to the programme, what sort of process can we put in place, and what are the main barriers that we've got to referrals at the moment. So I don't want to go too deep into programme overview and a massive ins and outs of the programme itself. Hopefully most kind of people have an idea of what the programme is, but I'll just for a little brief kind of intro to the programme. So the programme itself is a fully funded 9-month evidence-based lifestyle change programme, and it's for those individuals that have been identified as being high risk of developing type 2 diabetes through a recent HbA1c test, and that has shown them within that pre-diabetic range. So after a patient is referred through to us, they'll go through an initial assessment. It says 5 to 10 working days, but at the minute we've kind of got that down to about 24 hours of them kind of coming through referral wise, and then they'll attend our program for the next 9 months. So there'll be 13 sessions that are 90 minutes each. And in each of those sessions, they'll be looking at specific kind of topics and things throughout that session that aimed at promoting small lifestyle changes that can help majorly improve their health and well-being and reduce their risk of developing type 2 diabetes. One of the most recent studies that we had on the programme was done by the University of Manchester in 2022. It showed that the programme reduces the risk of developing type 2 diabetes by 37%. So it's a really effective program, and it works really well for those people that come through onto the program, and we'll kind of go through some kind of patient success and what they get out of the program later on. But yeah, that's kind of a little brief kind of overview of the program. If you jump on to the next one for us, please, Amy. There'll be a little pop-up. You might need to double click it. Perfect. So in terms of the options for patients when they come through to us, the programme is delivered in 3 separate ways. So we've got the face-to-face sessions. So they're delivered in community venues across the North East and North Cumbria, delivered in groups of up to, it says 20, but 25 people mainly. On average, it's around about 17, 18 people that will be at those first sessions. They can also access the programme digitally via our partner Second Nature. So that is one that they can do within their own time. And they'll do it all through a Second Nature's app with some support from a coach via web chat. And then we also deliver the programme remotely for some specific cohorts of patients that may have other accessibility needs that they may need. So, for example, patients that have a hearing impairment, we have sessions that are delivered with some BSL interpreters, and we have sessions for those with a visual impairment, sessions delivered in Urdu for patients from a Bangladeshi or Pakistani background, or we have sessions for ladies that have had a previous gestational diabetes diagnosis, and all those are available via the remote program that's delivered via Microsoft Teams. Go on to the next one for me, please, Amy. Can you just click through? I don't know if that's why I've got it. There we go. So eligibility wise, it's a pretty simple eligibility process. So any adult age 18 or over, and they have a HbA1c of between 42 or 47, or a fasting glucose between 5.5 and 6.9 in the last 12 months. Can't have previously been diagnosed with type 2 diabetes, and they must be able to participate in the program itself. Any previous gestational diabetes diagnosis at any point in the patient's life also eligible for the program, and they don't require an eligible blood test, so they can just be referred through. And in fact, those patients can also self-refer through to the program, so it's a little bit simpler for those that have had gestational diabetes. Where the patient is 8 years of age or older, we just ask that there's a conversation with a medical professional and that they're happy that any potential risks associated with weight loss outweigh any potential risks at that age. A couple of exclusionary criteria that are not on there, just to take into account. So the program's not available for any patient that is currently pregnant, or has a active eating disorder, or has had bariatric surgery in the last 24 months. So when you kind of think of running any searches for patients that may be eligible, just need to pop those exclusions in there as well, just to make sure that we get a full list of eligible patients. Does anyone have any questions on the eligibility process or eligibility criteria before I move on?
Yes, can I just check about other languages? You mentioned Urdu. If there's other language needs, how would they access?
Yeah, so the digital service is available in around 10 languages. So they can access that. Most of the Southeast Asian community languages are available on Second Nature, including Arabic. It's also available in Chinese and Polish as well on that one. In terms of the actual sessions, the face-to-face or the remote delivery, so we were commissioned just for the Urdu, or kind of it's also available in kind of Bengali and Gujarati as well, although those sessions are a little bit fewer and far between, just the number of patients that we have available for those. If a patient wants to attend a face-to-face session, and they're more than welcome to bring along someone to support them if that's needed. If they want someone to come with them and help translate, then that's absolutely fine. So they're more than welcome to do that as well. We just, as long as they let us know that they've got someone coming along with us, just to make sure that we can the venue that can facilitate an extra body, but that's absolutely fine. Okay. Next slide, please, Amy. So what I kind of want to kick off with is just understanding where we're at the minute within the North East and North Cumbria when it comes to people being diagnosed with pre-diabetes and then being referred through to the programme. So what we want to kind of look at is at the minute, based on the most recent NDH audit data that was released last week, we can see across the last 2 years, currently only around 1/3 of people that are being coded with non-diabetic hyperglycemia are being referred through to NDPP. And what we really want to see is a referral rate of around 50%. And that's in line with kind of some other areas, as well as parts of the Northeast that have been referring really well the last few years. So we can see there that, to 2023-24, it was at 34%. And then the last 2 years, it's just dipped down to 28%. That's leaving 7 in 10 people diagnosed with prediabetes not being referred through. So really the purpose of this kind of session today and moving forward, and kind of anything and kind of communication moving forward, is to understand how we can remove some of the barriers to that referral and increase knowledge amongst practices and how to get people referred, a bit about the programme as well, and just understanding what those common barriers through to the referrals, and which we'll kind of touch on a little bit later. But that's kind of just an understanding of where we're at this moment in time. And if we go to the next one. So if you add that last graph imprinted, you can see that kind of big difference here. So luckily Emma's on the call with us this afternoon, but just kind of an example of a PCN changing their referral approach and having a major difference in kind of their referrals through to the program. So we can see that from last year through to this year, their referral rates increased from 14 to 96%. So a huge increase in the amount of referrals that were coming through. So, you know, what we looked at doing here, what they looked at doing here was from June 2025, we had dedicated health and wellbeing coaches contacting eligible patients proactively, discussing the benefits of the program, addressing any concerns about the program itself, and then being able to submit them at point of conversation to the program. So it's made such a huge difference in terms of people coming through to the program, and it's also made quite a significant difference into the amount of people that are then actually starting the program and are staying on the program throughout, just due to the quality of those conversations that happened initially. So Emma, if you're still with us, I don't know if you just want to kind of, if you just want to, from your point of view, you know, anything that what you found with this kind of new process, or you know, anything that you'd like to share with us, that'd be fantastic.
Yeah, hiya everybody. My name's Emma. I'm the personalised care lead for Durham East Primary Care Network, so I oversee our health and wellbeing service and social prescribing service. So I'll try and keep this really short, but basically what we identified was through the data we were given for our referral numbers from Alex as to the referrals we were putting through to NDPP. We looked at why were our referral numbers so low, and we got patient feedback, which in our area ultimately came back to transport and accessing this programme face-to-face in the community. A lot of patients didn't want to access it digitally for different reasons. So with that feedback, myself and Alex had a discussion. We had a conversation around venues in our area, which was central to our 6 practices across the PCN. So we started using Belmont Community Centre for the delivery of this programme, which ultimately increased referrals anyway. However, the process into that, Health and Wellbeing Coach was a new role to us. However, she's also called Emma, had a background in diabetes prevention. So we decided, using our digital lead, we'd start running reports. So the reports that we run bring up patients across each practice who have had a review within the last 4 weeks. And if they're still eligible for NDPP, we then contact them proactively. We're doing it across the team now, so it's not just solely Emma, our health and wellbeing coach, because it's been so successful. So we use this as a continuous proactive piece of work across all the 6 practices. But we use approximately half a day for each practice, so for each of the 6. And we contact patients, we raise awareness of the programme, we let them know what it is, what to expect, what the topics are, where potentially they could access it, the way of accessing it, so whether face-to-face, digitally, and really just sort of promoting the benefits of this, which we found, I think, has been really successful, because whatever questions they might have, they can ask us those questions rather than saying, yeah, I'll have the referral, getting to the other side and maybe realising it wasn't for them for whatever reason, or, you know, they're fully informed about what the programme is. So yeah, I can't quite believe we're 13 months, Alex, into this, and Emma now, actually our health and wellbeing coach, is seeing where people have declined a referral previously. However, they are still pre-diabetic, they're coming back up in our report, so we're now contacting them again. So it's a continuous wheel, if you like, if people are declining. We get a lot of people declining who'll say, excuse me, you know, I'm making those changes myself at the moment and I think I'm doing okay. But then when we next speak to them, it could be, yeah, actually, I do need a bit more specialist support. So yeah, that's what we're doing. In a nutshell, so we identified the barriers to access, in which the majority was transport and accessibility. And then we keep in touch with Alex. We've got all the information we need. We keep up to date with what the programme is and how it's delivered and what the patients should be expecting. So we found that really positive, and hence the success story, which I'm really proud of.
Perfect. Thanks a lot, Emma. That was really helpful. I don't know if anyone has any questions on kind of that process before we kind of move on. I know that's not going to be a process that's applicable everywhere. You know, practices don't have coaches or kind of a wider social prescribing team, or it's something that's maybe outsourced to kind of a third party. But I think it shows the kind of a difference it made, just identifying this as an area that can be improved on, and an area where it can be a bit more proactive rather than kind of reactive, and you know, rather than just kind of reacting to kind of quaff or to anything else later on. It's just kind of a continuous kind of cycle, and hopefully it's, you know, obviously we don't see the data from our side, but hopefully in 12 months or so, Emma will be able to turn around and say that, you know, their type 2 diabetes diagnosis rate's gone down, or they'll be able to look, you know, have a look at, you know, some of the HbA1c results that some of these patients have kind of reported back to us. And I think you know, it's one of those where you kind of just obviously sowing some seeds for the future, and hopefully taking strain away from yourselves later down the line with diabetes care. So yeah, thank you very much for that, Emma. That was really helpful.
No problem.
If you could go through to the next one for me, please. There we go. So one of the other kind of options that we have available to us as well is looking at the difference between kind of opt-in and opt-out. So and it's something where quite a small change can make a big difference to the referrals coming through to us. So like Emma mentioned there, you know, a traditional method has been, you know, to say that you've been diagnosed, would you like a referral? And then that might then just culminate in, I'll think about it, I don't really know the program. You know, it then puts the onus on primary care to handle all those objections, especially if it's not something that you can kind of dedicate coaches to, or you have a lot of time to go through lots of different kind of scenarios, or you might not even have a conversation. It's just kind of done via kind of a short review. So what tends to happen in this kind of scenario is that patients are just given information on the program, they'll go away, and then nothing will come from it. They'll kind of no referral gets made, and they don't access the support. Whereas if we look at the opt-out approach, which practices are starting to pick up on a little bit more, is just when patients are coded and when they're diagnosed as pre-diabetic, rather than just being offered the program and then asking if they'd like to do it, it can just be a case of, you know, you've been identified as being high risk of developing type 2 diabetes, therefore we're going to refer you to the NHS Diabetes Prevention Programme. What that then allows to do is that it allows Read Wellbeing to then contact the patient and provide all the program information, go through all the objections that they might have about the program, take away that burden from primary care, so that you're not the ones having to kind of handle all these objections when you've got lots of different competing priorities, lots of, you know, other things that take up all the time, and you might not be able to dedicate time to just this specific this specific priority. And then at that point, the patient will choose whether they wish to take part or not. So at least then what we know is that every eligible patient is offered the support and they're able to kind of have some sort of contact with Read Wellbeing to then see if they want to come onto the program. So it just means that, you know, that choice is still there. It just means that the referral simply comes a starting point as opposed to it becoming the end point. So it'd just be a little bit of a kind of a small change that can, you know, really help increase the numbers of referrals coming through to us. And, you know, we've done a really big job over the last few years in improving our patient onboarding, how quick it is, how quickly they get onto the program itself, and the information that they're given, so that we can make sure that we're getting as many people onto this program as possible. So if we see kind of a big uptick in patients coming through via this kind of referral method, and, you know, like Emma mentioned, it might be that some of them, because they don't have all the information, they'll decide that it's not for them. But what we can do is we can kind of take some of that advice on board. We can take some of those reasons on board and tailor how we communicate and do what we need to do to improve that coming through. So, you know, with it being a fully funded service via NHSE, and with us being the provider, please feel free to make sure that you're putting as much onus on us to get these patients onto the program than trying to putting it all onto yourselves in primary care. I think, you know, get that referral come through to us, and then we can kind of take it from there. You know, and if we are seeing kind of low uptake numbers, then we can kind of respond to that however we need to do. But at least in this method, we know that people are being offered the program as opposed to just being provided information, then they'll kind of go away. because we all know like the responses we're going to get. A lot of us on this call might respond the same way sometimes. I know I'm trying to sort it out myself, or I'm not too sure. I'll think about it, which we most of us know that I'll think about it means I'm probably not going to. So kind of and the way that we communicate, we'll give patients kind of repeated chance within the first 30 days to engage. So it's not just one conversation and gone. We have different messages throughout that point to try and get them onto the program. Does anyone have any questions on that before I move on? No, that's fine. Perfect. So just a quick reminder of the actual referral process itself. So the main one that would kind of align with the opt-out approach is just completing the electronic referral form that is available through the primary care system. So that is just a case of getting up that form. Hopefully, some may have IT teams that can help build in some prompts for that form to come up. I know it was quite an important aspect of what Emma's team did in terms of their digital team, making sure that it was just a one click through from that patient through to the form, and then it can be filled in and sent to us. So it makes it a little bit more seamless.
Sorry, I forgot to mention that, Alex.
It's fine. It's fine. That just helps kind of, again, cut away some of those barriers of, if you've got a lot of things to do, if you can't find the form, don't necessarily know who to go to if you can't find the form, and then it just adds that extra layer of kind of friction in between. So obviously I know that's not going to be something that every practice is going to be able to do, every PCN is going to be able to do, but it's just kind of something that might prompt some discussions within your teams. But if not, that it should be pretty easy to find through the system. That's filled in, emailed through to us, and then we do all the work from there. We load them onto our system, and then we get in contact with them. Another option is doing searches for eligible patients and sending letters out to the patients with those results on it, and then suggesting that they call us. So that is kind of an option that can work well if there's a big bulk of patients that have been diagnosed but not offered or not had this conversation in the past. So it can be a way of getting that letter out to them. And then as soon as it comes through to us, then it'll be, or as soon as they ring us, then that'll be classed as a referral. So obviously, I think, the uptake rates on those are quite low, but it does, it does kind of serve as an extra option for patients if they've got a big kind of a backlog of doing it. It's not something I would recommend as the kind of usual referral process of sending that letter out if it's just kind of after every time or every review, because it's not always the most efficient. It can also be done via Flores text, via Accurex as well. So kind of the same information being sent out that you would do on the letter. Or if for whatever reason you do find yourself, with some free time, you're more than welcome to call our contact centre in and dial the referral in. But I don't think we've ever received a dial-in referral, and I don't expect us to do anytime soon. So I think the primary care system is definitely the way to go. I just saw a question. I just thought I'd try and answer that before Bethany kind of hopped out. When it loads. Yeah, so we've done a few few engagement directly with practices, and it's something that we're happy to do if practices want us to come in and do some training on not just on referrals but also on the program as a whole. So whether it's speaking to the nurses and HCAs about the program as a whole when they are speaking to patients, we can do that. And then we can also offer kind of similar training to this with practice managers or diabetes specialists who are going to be kind of responsible for the processes that get put in place when it comes to those referrals being made. So yeah, we're more than happy to kind of do that. If any practices want to organise that, they're more than welcome just to contact me directly, and we'll get that and we can get those arranged. Perfect. You can just go to the next one for us, please, Amy. Okay. So it's just in terms of understanding some of the common barriers to referrals. So these are kind of grouped them into kind of 4 main ones and just some underneath. So obviously we've got time and capacity. So limited patient contact, competing priorities, administrative burden as well. Like I mentioned, this is where it's kind of really important for just removing some of that friction, some of those barriers, and making it as simple as possible. Awareness and confidence. So uncertainty around eligibility of the program and the referral process. limited knowledge on the program, and also just lack of confidence discussing it with patients. And again, this is where I'd advise that practices get in touch with us so that we can kind of chat them through the program. We can increase that awareness about what the program is, so that they're comfortable having those conversations and they don't feel like that they're providing patients with incorrect information or kind of information that's kind of not fully formed. So please get in touch with our team and we can arrange that to happen, or we can send over some materials as well. And there's also obviously a lot of patient factors. So either patients not ready to make a change, they're either making changes by themselves, then the program itself, they might have some objections to, like Emma mentioned, either transport, where it is, all that kind of stuff as well. And then just concerns about committing to kind of that length of program. So I think this again is where the opt-in, the opt-out process works really well, because it allows us to take control of those objections, and it allows us to kind of provide those different options where all our customer service team are really well trained on doing that, and they'll get those options presented to them immediately as well. So I think some of those, again, it's just a case of that referral comes through to us and then we can kind of take it from there rather than it being objected to at the first hurdle. So I think it just helps kind of nudge it along a little. And then we've got process and systems. So whether it be that, in the millions of different priorities that a GP surgery is going to have, it might be that in terms of the NDH follow-up process, there might not be a specific process. It might just be ad hoc. Some practices might have kind of a very specific process of what happens when those blood tests come through in terms of whether they're pre-diabetic, if they're not, do they go through to a different program? What programs are available to everyone? The actual physical referral not being embedded into that pathway. So there's no kind of endpoint that ends in the referral. No preempts or templates. What we see a lot is individual administrators or clinicians that may go on holiday or may leave, and then they've kind of all that knowledge is kind of goes with them. Or the use of in-house coaching or local alternatives. So one of the big key differences with Emma's team is using that team to drive referrals through to this program, as opposed to trying to do all the coaching themselves on this specific topic. So, other PCNs or other areas may try and do kind of shorter weight management or diabetes prevention sessions with patients themselves, whereas what would kind of suggest is that allow us to do the pre-diabetic kind of aspect of that, and then it allows those coaches to be freed up to do other things. So where these nationally commissioned programs do exist, try and use as much as you can, so that we can kind of take some of that burden away from you as well. And then I think it's the next and the last one. So I know a lot of this has been focused on what practices can do and how they can kind of change little bits to get those referrals through. But it's obviously really important to remember that this is all about making sure that patients are able to make kind of healthier choices, have a better, increase their kind of life chances, increase their health going forward, and just making a really positive difference to themselves. And that's the whole point of this program. So after each program is completed, we send a survey out and we ask them to tell us what they've done differently, what they've achieved during the program, or what impact it's had on their lives. And these are some of the really common responses that we get. So in terms of what people have done differently, it's really about allowing them to take control over their habits, their nutrition habits, their exercise habits, and so they're fully in control. They're more conscious of it, and they're not just kind of going through day to day and being influenced from other areas, or just doing what they've always done. So a lot of people, have taken up diet awareness and tracking, eating more protein, swapping through to whole wheat alternatives, portion control. A lot of people are really surprised by what a kind of a good or standard portion of food looks like compared to what they might have already been eating. Drinking more water, a big increase in physical activity, and and crucially more sleep. In terms of what they've achieved, a lot of patients come back to us, letting us know that their HbA1c has moved out of that pre-diabetic range, which is obviously the whole point of this program. Significant weight loss for those that need to lose weight, getting up to those 10,000 steps a day, gaining control of their diet, increasing their good cholesterol, and also reducing their alcohol intake. On the weight loss, it's really important to kind of point out as well that this program is not just a weight loss program. It's not a case of That's the only point of coming on to program. We have more than enough patients that attend these sessions that don't need to lose any weight at all, and it's just about helping some of those other habits around their diet and some of those other risk factors that they might not have been aware of. In terms of the program impact, a lot, again, patients come back to us saying just in general, it's made them feel a lot healthier and more positive. It's reduced their risk of type 2 diabetes. They've got a far better understanding of nutrition, and it's helped cut through a lot of the information that they might receive online and a lot of conflicting information they receive. Really kind of positive fitness and stamina increases as well. More confident and getting to the point where they actually enjoy doing exercise, and it's not a chore. You know, a lot of the work we do around some of the sessions is helping patients understand kind of what their personal solutions are to being more active, and trying to help them kind of enjoy what they're doing, it rather than it just being something they feel like they need to do, and it helps it become a much more long-term impact for them as well. So that's some of the kind of key stories that we get back from people.
Great stuff. Thank you so much, Alex. It's really interesting to hear about that, and hear directly from Emma about the impact that's had in practice. So it's yeah, fantastic. Any questions, anyone? Feel free to pop your hand up, pop yourselves off mute.
Obviously, those questions be as specific as you need to be about kind of practice, or where programs are, when they take place, or yeah, anything specific about the referral process at all, or anything that kind of mentioned. Please feel free to ask away.
Stunned into silence.
I must have said everything I need to say.
Yeah, absolutely. You were so thorough, Alex. So it's whilst we're kind of thinking about questions and things, then oh, thanks, Emma. You've said you're happy for people to drop you an email for more info as well. So yeah, that's fantastic. You popped your email in the chat there. So yeah, there might be some questions that arise, but let's start to have a think about a bit of a breakout discussion. So kind of the so what for you in terms of the work that you do. So we've got a couple of questions here, and I will put you into rooms in a sec, hoping I've set those up correctly. I know people have shuffled about a little bit, and yeah, we might have lost one or two people, but we'll see how that goes. So just a couple of questions here, bit of food for thought. So if you've got a phone or something handy, do feel free to take a picture of those, and we'll try and post them into the chat of those breakout rooms as well. But yeah, you might lose access as you move over. So we'd like you to have a think about, you know, what does your current approach to this process look like? So and how you're kind of using it already. What are the main barriers you're potentially seeing, both from a practice and a patient perspective, and what opportunities, you know, ideas can you get from today to kind of help strengthen your approach? So it'd be great to hear some feedback on what you've been talking about, and kind of, you know, what are your thoughts on any of these particular questions. So if anybody would like to come in and share some of your conversation, that'd be great. Don't be shy.
So I think the common ones that came out in our group is that every GP surgery does it different.
Yeah.
Is a common one. So understanding more of the current referral process. We had some people who were new to roles, some people who are locum nurses, so they move between different GP surgeries. They're not always in the same practice. So again, that process can be different every single surgery that they go into. Different surgeries having different systems that they use for referral processes. So I think the main thing that we took out of that was understanding what is the current approach in the surgery that each person works in, and what is everybody's key roles in that, because some people had administrators that were sending you through referral forms, but other practitioners were speaking to the patient directly, and those kinds of things.
Thanks, Catherine.
And was there anything about kind of, how you might take this work forward? Yeah, I appreciate it's tricky when there's lots of different processes out there and everybody's different.
I think the main take home was for a lot of the people, because they were new to their surgery, was their awareness of trying to understand what their current GP surgery approach was and how they could go about improving that within each individual practice. So having more of a wider discussion, we talked about different job roles in terms of, like, some people were individuals who were handling large caseloads, and some people had wider teams that were handling caseloads. So it was very much about understanding the current referral process. Quite a few people felt like they needed was more of the understanding in their own practice what their approach was currently.
Great, thank you. Any other comments or thoughts from anybody else? Did anybody think anything different? No. And before we finish, any final questions or anything for Alex? If you don't mind, Alex, we could, pop your contact details alongside the recording of this, so that
absolutely.
If people would like to kind of come back to you and have a bit of a conversation,
yeah, of course.
Yeah, no doubt they will. So
yeah, not a problem at all.
Great. So thank you very much, everybody, for joining. Great to see you all. And yeah, what we'll do is we'll put this recording on the Boost website and YouTube channel and send the link out. So please do share it with colleagues or, other contacts that you have in primary care who might be interested in learning more about the NDPP. And yeah, thank you so much, Alex, for coming along. It's been really fantastic to have you here and hear all about the work that you've been doing and the impact that it can have.
No problem. Thank you very much.
Great stuff. Thanks, everyone.
All right.
Have a good rest of the day.
See you later. Bye-bye.
Thanks. Bye.